determining scene safety. I'm determining or considering mechanism of injury, nature of illness. Motor vehicle rollover ejection sounds like there's a pretty significant mechanism involved here. Determine the number of patients. I see one patient. Do I have one patient?
Yes.
Okay. I'm also going to go ahead and call for advanced life support at this time to get them started in my direction. And I'm going to immediately direct my partner to neutral align the head and hold C-spine. C-spine is now controlled, yes?
Yes.
Okay. Approach the victim. A general impression is poor because she's supine on the roadway, doesn't appear to be moving around. She ejects from a car. Hello, hello, can you hear me? Does she respond to voice or shape? Does she respond to painful stimuli? She does not. She is unresponsive at this time, and that is the patient's chief complaint. The fact that she's unresponsive, I would immediately direct my partner to use the jaw thrust to open up the airway. Will I check her breathing? Is she in fact breathing?
No.
That would be too easy. Then we would just bag her, put her on a board, and drive her to the hospital. Yes, she is. Is there adequate rise and fall to the chest? Okay. I'm going to go ahead and check the carotid pulse. Does she have a carotid pulse?
Yes.
Yes. Do I see serious external bleeding anywhere that I must control?
Yes.
Where?
Left femur.
Left femur. I will immediately direct my partner that's not holding C-spine to expose the left leg and femoral area and go ahead and apply direct pressure to that bleed and see if we can get it under control. Okay. I'm checking skin color, temperature, and texture. What do I get?
Cool and clammy.
She's cool and clammy. This indicates possible shock. We need to speed things up and get her transported to the hospital. As I'm watching for the rise and fall of the chest, can I get a quick respiratory rate here? 22 in labor, outstanding. I'm going to go ahead and immediately direct my partner to place a non-rebreathing mask on her at 15 liters per minute and ensure adequate ventilation by watching for good rise and fall of the chest. I now want to go ahead and begin my rapid trauma exam. I'm going to quickly begin checking her head, forehead, and facial area for any decap, PTOS, any obvious injury. Am I finding anything?
No.
Okay. I'm going to go ahead and look at the anterior portion of the neck, look for decap, DTLS, tracheal deviation, jugular venous distension, or any other soft tissue injury. I will also feel behind the cervical spine for step-offs. Anything found? I will now direct my partner to size and place the cervical collar. I continue my assessment. I'm checking clavicle, sternum, watching the rise and fall of the chest. Okay. Am I finding anything on the chest at this time? Rise and fall, everything's good, bad? What do we got? Okay, I'm going to go ahead and start palpating the abdomen. I'm watching her face to see if she grimaces, also listening to see if she cries out in pain, determining if there's point tenderness, any rebound tenderness. Is the abdomen rigid, distended?
It's rigid. Rigid.
This could indicate internal bleeding, which would be in line with the shock-like symptoms I just encountered. We need to speed the process up and get her transported. Gently pushing down on the wings of the hips, pulling up, seeing if they move, listening for crepitus, and also watching to see if she grimaces at all. Is the pelvic area stable? I'm going to quickly check the right leg. All right. If I have access, I'll check distal pulse at the foot. I'm also going to pinch to see if she responds neurologically. Anything? Okay. Quickly check the left leg. Again, if I have access to distal pulse, I'll check it. Also pinch to see if she responds neurologically. Anything?
Swollen ankle.
Swollen ankle. Is the skin intact?
Yeah.
I identify this as a secondary musculoskeletal injury, and I will treat this en route. Right arm, distal pulse, pinch, no response. How's the arm? Any injury? Left arm, distal pulse, pinch, any injuries?
Disinformed.
That's your wrist. It's swollen and discolored?
Yes.
Identify this as a secondary injury. We'll treat it en route. I would now like to log roll my patient to examine posterior and place her on the spine board. I have a possible ankle injury. You said it's swollen ankle, right? Ankle fracture. Possible wrist injury. Well, what I'd like to do at this time is have my partner stabilize the wrist as we log roll her away from her injured ankle. I will quickly.
What about the femur?
I'm sorry?
The femur.
I forgot there's a femur. Is it broke? Okay. I will log roll her the other way. You understand why now?
Yeah.
I put this over this, but you're right. This is over all of that. So we're going to try and secure this leg and roll her to the side. I will quickly examine posterior for any obvious injury and slide my hand down the spine for step-offs. Am I finding anything?
No.
Okay, we're now going to place her on a spine board. We're going to strap her into this board, torso, legs, head last. While she's being strapped in, I will direct my partner to obtain baseline vital signs such as blood pressure, heart rate, rechecking respiratory rate, and checking pupillary reaction. I will attempt to get a sample history on scene if it is available to me. Now we're going to get her right into the ambulance. In the back of the ambulance, we're going to initiate transport. She was a high priority on scene based on mechanism of injury and the fact that she's unresponsive, and she remains a high priority right now. I will also reconsider the mechanism of injury and reevaluate my initial assessment. I'll pay close attention to mental status and ABCs. I'm now going to go ahead and perform a detailed physical exam. Now I'm again inspecting the face. I'm checking pupils. I'm looking for battle signs, raccoon eyes. Am I finding anything?
No.
I'm going to recheck the neck for tracheal deviation, jugular venous distension. I'm going to make sure she's exposed. I'm rechecking the chest, watching for adequate rise and fall. I'm also going to quickly auscultate lung sounds at this time. Is there equal air movement? Get back to the abdomen, exposed. I'm now looking for soft tissue injury, seeing if she grimaces or cries out in pain. Expose the lower extremities, pelvis. I would examine the inguinal region if it was necessary, but there does not appear to be any pelvic injury, so I don't think it needs to be examined. I will now quickly check the left leg again. We have that femoral injury. If it is in fact a fracture, we're most assuredly going to continue splinting that with the spine board and pad any voids that we find. Checking the right leg, okay? With the shoes off, I'll check distal pulses in both feet. Do I have distal pulses?
Yes.
Okay. Does she respond neurologically to pinch in either foot?
No.
Okay. Back up to the left arm. Again, I'm going to check the arm. Pulse, pinch. Does she respond? Okay. Right arm. Pulse, pinch. I know that she may have a secondary injury to the wrist as well. So I'm now going to direct my partner to check her vital signs every 5 minutes because she's a priority patient. I'll check my interventions. In this case, I'm going to go ahead and check the oxygen I've got on her, now rebreather 15 liters per minute, to make sure that's effective, make sure she doesn't need bag-assisted ventilations. I've already reconsidered my transport decision. She's a high priority. I will observe her during transport for changes in condition. I will make sure that the wrist, ankle, and femur have been secured properly. I'm using the spine board to secure the femur right now, and we'll splint the wrist and ankle. I will keep her covered up with a blanket and continue oxygen therapy, treating her for shock. If she becomes unstable, I can always elevate the foot end of the board. My clinical impression of this patient is a multi-system trauma, possible internal bleeding with secondary musculoskeletal injuries. My treatment for this patient is through. Do you have any questions? What I missed?
What would you do if it was an open fracture?
Cover it with a dressing.
Like you don't splint it, right?
The spine board will be the splint for that. Yes.
Will you dress it like in the field, or do you?
Yeah, we control bleeding in the field. Absolutely.
Okay.
Yes.
So the major bleeding is controlled at the very beginning of the
Absolutely. Remember, circulation, heart rate, skin color, skin temperature, serious external bleeding. Absolutely.
And then the secondary ones are what are like while you go down through your.
I will mention secondary injuries. Secondary injuries are injuries that which, if left untreated as seen, will not kill the patient. That had to be dealt with right away because she could bleed to death. But if they said to you, let me ask you this. What if they said there was a bleed on the left thigh? Don't automatically assume it's a femur fracture. Could they still have a soft tissue injury? My next question would be, is it bleeding heavily? Is it bleeding controlled? Oh, it appears to be dark red in color, venous bleeding. We're going to control that. We're going to immediately control arterial and venous bleeding. But if it's a scrape, right, an abrasion, later.